Hey everybody, so this video is going to wrap up the material on blood pressure from chapter 15 and lead us nicely into next chapter, which is respiratory system. So we talked a lot in the past few weeks about blood pressure and why it's so important and how we regulate it and how the sympathetic controls it, how the parasympathetic controls it, all that stuff. But before we move on to the respiratory system, just wanted to highlight some other effects of blood pressure besides just driving blood flow. And so we're going to look at what I'm going to call other types of blood pressure and why they're so important. And as always, we're going to try to explain stuff in the context of like real patient cases, because that's why stuff matters, because it affects us. And so here's our first patient that's going to help us highlight some other types of blood pressure. So this little girl is 3 years old. As a result of war in her country, she's been unable to get food for some time, as you can see. And maybe she looks as we might expect for somebody who is starving. Her arms are very, very thin. You can see her legs really just look like skin and bones. But if you look at her belly, if you look at near her GI tract, it actually seems like we have the opposite situation where that particular tissue is swollen, it's bigger. Maybe something that we wouldn't expect. We're going to see that this is actually a blood pressure problem. And if you want, take a second, just like we always do in class, to take what we know and try to explain what's going on here. How could somebody who's starving have a distended or swollen belly? So patient number 1. Patient number 2, very different but very similar cause. This guy's name is Jose, he's 60. He's gone to the hospital as a result of his left ventricle failing. So this is a heart condition. However, what they notice pretty quickly is that he's having difficulty breathing. And what they notice is that he seems to have a lot of fluid in his pulmonary tissue. His respiratory system, his lungs, are swollen with fluid. Weird. So, swollen belly due to starvation, and swollen lungs due to heart failure. So the goal of this first section of this video is to explain how we might swell up a tissue or how we prevent it from swelling up with fluid. So really both of these patients have blood pressure irregularities. But this blood pressure that we're going to talk about here is a little bit different than the blood pressure that we've been talking about before. So just as a reminder, we've talked about blood pressure in the past, so before, in the context of being necessary to drive blood flow. Blood always flows from high pressure to low pressure, so we needed sufficiently high pressure to drive that blood flow. But turns out that the reason, and you guys might remember this, the reason that we need blood flow is because we need blood to be delivered to the tissues, which will allow for fluid, ions, glucose, gases to be exchanged with the tissues. And so the place that we're driving blood to, the place where we're exchanging fluid, is at the capillaries. Because these capillaries are specially designed to allow that to happen. So there are a lot of different kinds of capillaries, but the general idea is that they have a very thin wall, unlike your arteries or your veins, that allows for easier exchange of materials, for example, like gas. So this very thin layer between the blood and the interstitial fluid or the tissue allows for things to pass. Additionally, we have little junctions that allow for small dissolved substances to pass from high to low, just using diffusion as well. So in addition to being thin, these capillaries are also structurally designed to allow for things to pass through. And as shown here, they can also transport larger molecules using transcytosis, so an actual process to get things through. But basically the general idea is that capillaries are these sites of gas exchange, nutrient exchange, and fluid exchange. And pay note to that last one, fluid exchange. Because if we think about those patients that we saw, we talked about how the first one, Fatima, had too much fluid in her digestive tract, or at least in the tissue. Jose had too much fluid surrounding his respiratory system. So our first clue is that at the capillaries, at these specific tissues, there's too much fluid being lost. So it's this idea that fluid is exchanged at the capillaries. But what drives fluid exchange? And so let's go into that because it's going to help us understand both of the patient cases at the beginning. All right, so we have diagrammed here an arterial. So we have an artery up here, it fed into an arterial, and that fed into a capillary. That capillary then is the site of gas exchange, fluid exchange, molecules like glucose or ion exchange. And then that blood exits into the venous system through the venules. But the idea is that the blood on the arterial side is coming in fast and it's coming in hard. And because of all this blood coming into the capillary, there's a high pressure from all that fluid. So we've seen in the past that one way to increase pressure in a vessel is to add more fluid, to add more blood. And so as this blood comes in, we're going to see that the pressure in this side of the capillary, due to the fluid, is pretty high. The osmolarity in this fluid is not high enough. And so what ends up happening is that the pressure from the fluid overcomes the pool of osmolarity. And so water and fluid just get forced out of the blood vessel. Because remember that if osmolarity were high enough in the blood, water would want to stay there due to osmosis. But what this is saying is that on the arterial side of the capillary, the pressure due to the fluid, due to the blood coming in, is higher than the osmotic pressure, and so water and fluid is driven out. But the thing is, if that fluid stays in the interstitial space, if it stays in your tissues are going to swell up. Clue number 2 for our 2 patient cases. We got 2 swelling cases. One was in the lungs, one was in the digestive system. So they're doing a lot of this, filtering water out of the blood, but for some reason they're unable to get it back. So let's talk about why they're not able, or why someone might not be able to get it back. The way you and I usually get water back into the bloodstream, or at least get it out of the space, is either using lymph, the lymphatic system, to get some of that excess fluid out of the tissue. But the one we're going to focus on is how we actually get the fluid back into the bloodstream, how we absorb it back. And the way that happens is because as the blood travels through this capillary, the fluid pressure begins to decrease. Some fluid has been lost, so there's not as much fluid in the capillary, so we'll lose pressure because of that. We'll also lose some pressure because as the blood travels to the right, due to frictional forces rubbing up against the walls, for example, some of that pressure will be lost as well. So now if I look at this side, the pressure due to the fluid is relatively low compared to the osmolarity. So now on this side, osmolarity dominates, and by osmosis, fluid goes back in. So the idea is that on this side, fluid is driven out by high fluid pressure, and it is absorbed back in due to osmolarity being higher than the pressure. And so if we just give two names to these two kinds of pressure, so remember, one of them is the pressure due to fluid, the other one is the pressure due to osmolarity. We're going to give the pressure due to the fluid hydrostatic pressure. So we can just say that on this side, there's a higher hydrostatic pressure, and that filters fluid out. But on the venule side, there's a higher osmotic or oncotic pressure. And as a result of this osmotic pressure, water wants to flow back in just due to osmosis. And so normally in our tissues, we have this constant tug of war where we're saying we filter out blood on this side and reabsorb it on the venule side. And the idea, again, just a third way to show it to you, is in number forms. As fluid comes in to the arterial side of the capillary, there's a higher hydrostatic pressure compared to the osmotic pressure, the pressure due to osmolarity. So the pressure forcing fluid out is greater, and overall we'll lose some fluid from the capillary. But as we move towards the venous side, the hydrostatic pressure has now decreased because we've lost fluid, because there's been frictional forces on the fluid. And you can see now that the osmotic pressure, even though it hasn't changed from the beginning, is now greater than the hydrostatic. And as a result, water is going to be drawn back into the capillary. And this is what should happen. We lose some fluid on this side, but then we gain it back on this side, and our tissues don't swell up. Okay, so this is normal. This picture right here is what's happening in you and me, in our lungs, hopefully, and in all our tissues, where our tissues are not swelling up. So I'll ask you this question in class. You can look it over now as you watch the video. This one as well. We'll look at these questions at the beginning of class on Thursday just to make sure that you watch the video, but also to make sure that you understand the concept. And if not, we'll talk more about it. We'll also try working on problems to explain Fatima's case as well as Jose's case. But I wanted to touch on Jose specifically, and maybe in anticipation of Thursday's class, you can think about why Fatima's tissue, her belly, is swelling up with fluid. And my hint, wink, wink, is that remember that in her case, she's not eating. That means that the protein content in her blood is really, really low. So try thinking about what that means about the osmolarity and all that stuff. But let's look at Jose's, because I wanted to show you some pretty interesting examples of these changes in hydrostatic pressure and how we can use it to diagnose heart failure, but also which side of the heart has failed. So with Jose, we saw that it was his left ventricle that was the problem. And the nurses and the doctors discovered that he had fluid buildup in the pulmonary tissue. And so if we look at the left ventricle and think about where it pumps blood to and where it gets blood from, that's actually going to be our key to understand why his lungs are swelling up with fluid. So this is what should normally be happening in our system, where the left ventricle gets blood in through the pulmonary veins, and then it pumps blood out into the systemic circulation using the arteries, so the aorta, for example. But if the left ventricle begins to fail, what happens is now, instead of the left ventricle being able to pump that as much blood out into the arteries, now some of that blood is going to get backed up. As a result, the pressure in the capillaries that feed the lungs increases. There's an increased hydrostatic pressure. But we know that if there's an increased hydrostatic pressure, that is the pressure that drives fluid out of the blood vessels. So as a result, his left ventricle failure would lead to more fluid accumulating in the pulmonary system, in the interstitial space. And we'll talk about, when we talk about the respiratory system, why that fluid can make it so difficult to breathe. So that's left ventricle failure, where we have this problem of the left ventricle failing, the blood backs up into the pulmonary circulation, increasing the hydrostatic pressure and driving more fluid out than we can reabsorb. But if we think about what would happen with right ventricular failure, take a look at that of these pictures and think about where blood would back up to if the right ventricle failed. And this is where I'll pause and let you think about that. That's correct. If the right ventricle fails, blood now is going to back up into the systemic circulation. Not into the pulmonary, but the systemic. So we should see increased hydrostatic pressure systemically. And we can actually literally see that. So this person, for example's right ventricle has failed. You can see blood backing up into the veins in his neck. You can actually see that live. You can see that increased hydrostatic pressure. But you notice that this tissue is not swelling because we can't exchange fluid at the veins. But if we look at, for example, his feet that have a bunch of capillaries, all that increased hydrostatic pressure, especially in the lower extremities with all the blood pooling when he stands up, all of this increased pressure in the systemic capillaries leads to more hydrostatic pressure, leads to more fluid being forced out at these capillaries. And you can actually see all this fluid accumulating in the tissues. You can see that this person with right ventricular failure, you poke this tissue and it's like a waterbed. It's so swollen with fluid due to that high hydrostatic pressure that you can actually still see that mark from that person's finger. So that's pretty crazy that you can diagnose right ventricular failure from left ventricular failure based on swelling in different parts of the body. If somebody comes in and says, I can't breathe, that could be left ventricular failure. If someone comes in and says, my feet are swollen, that could be right ventricular failure. Something you wouldn't really expect to happen as a result of cardiac issues. Can be an easy, non-invasive way potentially to give you some info to diagnose that ventricular problem. So these are two final kind of types of blood pressure. We had hydrostatic pressure, which tends to force fluid out of the capillaries. And then we also had osmotic pressure, which tends to bring fluid back into the capillaries as it's attracted to osmolarity. And so for Thursday, if you could review these two cases, Jose, we talked about in detail, but I also want you to think about Fatima's case and see if you can explain why her tissues are swelling, because she does not have ventricular failure. It's a completely different thing. And maybe you could think of at least one other case where your body has swollen up, maybe a particular site, as a result of maybe like injury or staying on a plane too long, where you've gotten some accumulation of fluid in the tissues. And we're going to try to explain those types of cases in class at the beginning of class on Thursday. All right, so Jose, left ventricular failure, trouble breathing. So now what we're going to jump into is how we breathe at all. How do we breathe? How do we bring in air? How do we get air out? Why was it so hard for Jose to breathe when his lungs were full of fluid? This is actually chapter 16. That's a little typo there. But we're going to start with chapter 16, the mechanics of breathing. And we're going to have kind of a slightly different type of patient case. It's something that maybe we've all experienced. I've experienced it. Where you're breathing so fast, you're breathing so hard as a result of being scared, being stressed, being in pain, or maybe doing it voluntarily, that you actually start getting dizzy. And people tell us that one way to treat this is to try to breathe through a paper bag. So to start off our respiratory block, we're going to try to understand this particular patient case. What does hyperventilation mean? How do we hyperventilate? Why do we feel dizzy when we do it? And why might a paper bag actually help? This is going to help us introduce some key concepts about the respiratory system. So keep this in mind as we go through the next few minutes. And if you want, pause the video, and as we usually do, come up with an explanation. Based on what you know now, why do you get dizzy if you breathe too much? Why would a paper bag be good? So as we jump into explaining that kind of case, let's just quickly review why the respiratory system is so important and all the functions that it has. Turns out it's really important for helping you regulate your blood pH. It's really important for pH homeostasis. We'll talk about that in a few weeks, but just introducing it now. Helps you trap pathogens and substances, smoke with all that sweet mucus that we make. Helps us talk. No respiratory system, no talkie. But the thing we're going to talk most about is the fact that the respiratory system helps us bring in gases, expel gases, and helps us exchange those gases between the environment and our blood. And specifically, what we're trying to do is to get oxygen from the atmosphere into the airways, into the lungs, specifically the alveoli, and get that oxygen to go into your bloodstream, and then ultimately get that oxygen to go into your tissues. First goal accomplished. Oxygen into the blood, oxygen into the tissues. But at the same time, what we need to do is to get carbon dioxide that's being produced in the tissues as a result of metabolism, get that CO2 to go into the blood, travel to the lungs, and then get expelled when we breathe out. That's our second goal. So our first goal, get oxygen into the tissues, get CO2 out of the tissues. And so we essentially have these two sites of exchanging gases in order to accomplish those goals. First, we have to exchange gases across this surface from the lungs to the blood, or vice versa. And this is what's known as external respiration, where we're exchanging gas from the lungs to the blood or the other way around. And it's known as external because we're still dealing with the external environment. This oxygen that's coming into the lungs, that is still oxygen from the atmosphere, from the outside world. But then what we need to do is to get that oxygen into the tissues, and this is what is known as internal respiration, where we're exchanging gases from the blood to the tissues or vice versa. This one's known as internal, or at least the way I remember it, think about it, is that this oxygen molecule is now a part of us. It is now inside our body, inside our blood. This is not oxygen from the atmosphere. It is now ours. And so this is internal exchange. This is still exchanging with the external environment. So this is our goal: oxygen in, CO2 out. So we essentially need to first exchange from the alveoli to the blood using the external respiration, and then ultimately exchange internally at the tissues. This is our goal. And before we get any further into how we actually make this happen, just wanted to remind you why oxygen is so important and why CO2 sucks, or where it even comes from. You might have seen this back in bio days, but I think it's pretty awesome, and I think if we're learning about oxygen and CO2, it's important to keep in mind why they are so important. So just as a reminder, your cells require oxygen to make the majority of ATP. So there was this thing, because I remember, electron transport chain that relied on oxidative phosphorylation to make tons and tons of ATP. You don't need to remember this, and you don't need to remember the electron transport chain that I'm showing here. But I just wanted to bring it up to remind you of what oxygen's role is in our body. You guys might remember all this Krebs cycle stuff and glycolysis and breaking down glucose to make ATP. We would make very, very little ATP if it weren't for oxygen, just as a reminder, because oxygen is basically going to serve as a final electron acceptor. And what it's going to do is basically allow for ATP to be made. And that is really the only reason that we take in oxygen, is to allow it to make ATP. So critical, you breathe in order to make ATP. Carbon dioxide, though, is a waste product during all of this process. You can see that as we're metabolizing glucose, for example, we get into this cycle where we're breaking down these products, we're making energy. However, we're also making CO2 as a waste product. It is the poop of our cellular metabolism. So, as important as oxygen is to get in to help us drive the synthesis of ATP, it's as important to get CO2 out because it is a waste product. And we'll see in a couple weeks that this waste could literally kill you if we don't get it out. All right, so oxygen super important to help us make ATP. CO2 super important to get rid of because it is trash. So how do we actually affect oxygen and CO2 levels through breathing? So this process of hyperventilating is just going to make us increase oxygen in our system, because every time we breathe in, we'll get more oxygen. It will also help us decrease CO2 in our system, because every time we breathe out, we'll decrease or get rid of CO2. And so really what's happening when we hyperventilate is that we're just doing this. Think of like ventilating a house or ventilating a room. All you're doing is having a bunch of air coming in and out. So that's really all ventilation means, is just getting a lot of air in, getting a lot of air out. And in our case, that means getting a lot of oxygen in and getting a lot of CO2 out. And so what we're going to say is that we're ventilating specifically the alveoli, the critical sites of gas exchange in your lungs. And you'll notice that at the alveoli we get in gas, but we always need to send blood to the alveoli as well, known as perfusion, because that's how we actually get the oxygen into the blood and get the CO2 out of the blood. So we kind of have this tag team effort at the alveoli, where we ventilate the alveoli, get gas in, but we also need to perfuse or bring blood to the alveoli so that we can exchange gases with our internal environment. And so this graph is just summarizing what happens as a result of ventilation. You'll notice that as ventilation increases, as we get more air in and out of our alveoli, you'll notice that the content of oxygen increases as we hyperventilate. We're getting more oxygen in. The content of CO2 decreases as we hyperventilate because we're getting more CO2 out. But this brings us maybe to our first case or first explanation. Usually when some people hyperventilate, you can try it now if you want, don't get too crazy with it. But when I've hyperventilated as a result of extreme pain when I had surgery on my knee a long time ago, what I remember happening is I felt very dizzy. My tongue went numb and I almost passed out from the pain. But all of that was due just to the hyperventilation. And if you notice, what this hyperventilation curve is saying is that when you hyperventilate, you actually have tons of oxygen. So I didn't pass out or almost pass out because I didn't have oxygen in my blood. And so what I want you to think about for Thursday is, why might somebody pass out if they're hyperventilating? And this question will introduce the idea. If somebody is hyperventilating, do you think their blood vessels would tend to constrict or dilate? Think about it. We've talked about how oxygen and CO2 affect blood vessels in the past. See if you can call that back for this question. So again, hyperventilation decreases alveolar CO2. It increases oxygen levels. And so the reason somebody really breathes in through a bag is not because they're trying to get oxygen or get more oxygen. It's because they're trying to keep their CO2. And we'll see in class why that CO2 is so important. So this guy, he's hyperventilating, he's feeling dizzy, he's lost too much CO2. That paper bag is going to help him keep that CO2 in his system. He's going to breathe it out, the paper bag's going to trap it, and when he breathes in, now he's going to take in more CO2 than he would have otherwise. So try thinking about for Thursday why CO2 levels might be so critical to maintain, and why, if they get too low, that might lead you to pass out. You can check this slide out for the answer, basically. So I'll just leave it for now. You can pause and check this out, and this should help you answer that. But we'll cover it in class together with some in-class problems. All right, so oxygen in, CO2 out. We need that to happen because the oxygen is going to help us make ATP. The CO2 is a waste product, so we need to get that out. But how do we actually get that air in out? How do we actually get air into our system and get air out of our system? This little guy, even though this is a little tough to watch, is going to give us some clues about how we actually get air into or out of our system. So this will be another patient case that will help us understand the respiratory system. So this little baby is at rest. You can see that he's awake. And you can see that he's struggling. in the sound, you can actually hear him crying and whimpering when he breathes. It's very difficult for him to breathe. And you can actually see all the effort that he's using to breathe. His chest is rising a lot. You can see his ribs when he breathes in. So very deep breaths, even though he's just resting. And so what that kind of gives us a clue about is that a lot of muscles are involved in helping us breathe in or out. And the goal of those muscles is basically to generate a pressure gradient. Because what we know about blood, what we know about ions, and now what we know about air is that everything goes high to low. Like I told you in week 1, this high to low diffusion stuff is like 30% of physio. And homeostasis is like another 50%. But what this little guy was trying to do was to use his muscles and his respiratory system to generate a pressure gradient to drive air from high to low. And that's really how we breathe, is we generate a pressure gradient. So if someone were to ever ask you, and if that someone were me, and if that sometime were exam 3, what is the main job of the respiratory system? You could come up with a lot of answers. But I would make the argument that the first and maybe the most important job, at least initially, of the lungs, of the respiratory system, is to generate a pressure gradient. Because without a pressure gradient, no air goes in, no air goes out. Just like the heart's job is to generate a blood pressure gradient, because no blood would flow otherwise, the lungs are going to do the same thing. And so how do we actually create that air pressure gradient? It's going to be the exact same way that the ventricles did it, the way that the heart did it. We're going to change the volume of the lungs to change the pressure of the lungs. Just like we saw with the heart or the ventricles, anytime we take a particular chamber and we decrease the volume of that space, that increases the pressure. There's this inverse relationship between volume of the space and pressure of the space. And so that's all we need to do with our lungs. Pretend this is your lung. If I want to increase the pressure in your lungs, I need to decrease the volume of your lungs. If I want to decrease the pressure of your lungs, I need to increase the volume. So if we look at this lung and kind of how it's attached, we're going to get some clues about how we can actually cause it to expand and get smaller. So we have this lung that is attached to the diaphragm on the bottom portion, but it's also attached to the rib cage. And what all of these muscles are going to do, for example, they're these intercostal muscles along with the diaphragm, is that they're going to allow us to control how big or how small the lungs become. When these muscles contract or relax, that's going to change the volume of these lungs. And the way that we're going to connect the lungs to these muscles is through this pleural fluid. So we have this lung, this structure that contains kind of our alveoli, the airways, etc. But what we need is for it to be connected to these muscles, the diaphragm and the rib cage and the intercostal muscles. We're going to do that by using these two membranes, one attached directly to the lungs and the other attached directly to the muscles and the rib cage. But in between these two membranes, we have this thin layer of fluid known as the pleural fluid. And this pleural fluid is basically going to serve as the glue that connects the lungs on the right side to the rib cage on the left, or the lungs up here to the diaphragm at the bottom. So literally, basically, this pleural fluid is kind of like glue that is connecting the respiratory system to all the muscles that are going to help us control it. And so the idea is that if the rib cage gets pulled out this way, because those muscles contract. For example, because of this pleural fluid connection, the lungs are going to get pulled out that way. If the diaphragm contracts and gets pulled down, the lungs are going to get pulled down as well. So this is the way that we're going to generate our respiratory pressure gradient, is by having these muscles contract and relax and using this pleural fluid to cause the lungs to get bigger and smaller. So for example, let's say your diaphragm is relaxed, your lungs are being pushed on from the bottom. But if I contract my diaphragm, you'll notice that the diaphragm sits flat during contraction. But because of the pleural fluid connection, the lungs get pulled down as well. But their volume, if it increases, is going to make the pressure decrease. And now you'll see that what happens is that air rushes in towards that lower pressure. So anytime you breathe in, that's because your lungs are expanding, and as a result, the pressure in your lungs is falling. And so what this shows is how we actually create the pressure gradient to breathe in. And it indicates that we actually need a lot of energy to breathe in. We need to contract the diaphragm. The skeletal muscle has to contract. To breathe out, we just need to do the opposite. The diaphragm relaxes. It starts applying pressure to the bottom of the lungs, and the lungs get smaller. But if the lungs decrease in volume, that means that the pressure in the lungs is going to increase. And since air always flows from high to low pressure, air is going to flow out our mouth from high pressure to lower pressure outside in the atmosphere. So this is how we generate the pressure gradient during breathing out, or at least when we breathe out normally, our normal tidal volume. And so what this indicates is that when you breathe out normally, like probably what you're doing right now, you're super chill, super relaxed, you're not stressing, maybe you're not exercising. No energy is required to breathe out normally. The diaphragm just pushes on the lungs, makes them smaller, and air flows out. Also, we'll see in class on Thursday that another reason you don't need air to breathe out is because we have these little elastic fibers around the alveoli that are basically like rubber bands that when you stretch them out, that requires work. But if you just let them go, they naturally want to snap back into place. No work required. So your lungs naturally want to just snap back due to the muscles relaxing, but also due to the elasticity of the fibers and of this tissue. So that's a brief intro to how we actually get air into and out of the system, why that's so important. We've seen a few cases in this video that I want you to try to think about more for Thursday when we tackle some questions. So we've seen Fatima, who had swelling in the abdomen due to starvation. We had Jose, who had swelling in the respiratory system due to heart failure. We had somebody who was hyperventilating, which led them to feel dizzy and potentially pass out. And then most recently, we had a newborn who was using a lot of muscular effort to breathe in and to breathe out. So maybe try writing those four out, come up with explanations, diagram it, and then we'll approach those more in class on Thursday. Hope you guys have a great week, and I will